You are back on another episode of the Kentucky Hospital Association podcast. This is Trey Watson, joined as always by Ginger Dreyer from the Kentucky Hospital Association. Ginger, how you doing?
I'm doing great, Trey. Are you ready for the end of the year and all the fun stuff that goes with it?
Yes, I threw my back out a little bit last week putting up lights, so uh, and then had to go buy more lights and more extension cords. So uh, the holidays are upon us. Always a fun time. Of course, if the holidays are upon us, that also means that a new legislative session is just around the corner. So we are joined today by KHA Director of Government Affairs, VP of Government Affairs, Jim Musser. Jim, how you doing, buddy?
I am doing great, Trey. Thanks for having me on again.
Absolutely, and there's a lot going on. Obviously, a new administration in Frankfurt or in Washington D.C. Kind of same old, but maybe a little bit emboldened in some areas, especially when it comes to healthcare in Frankfurt. We can talk about for 2025, but before we get into that, I want to just mention real briefly because there is still time left on the clock in 2024 in Washington, D.C., and it sounds like there's going to be some continuing resolutions, including a healthcare package. And I wanted to see if you wanted to give a little bit of insight. I know you've been working a little bit on that and kind of know some of the juicy bits of goodness inside of it. If you wanted to kind of touch real briefly on what we might see out of Congress here during the lame duck over the next week and a half.
Well, it is a very lame duck. Speaker Johnson has indicated that they are close to a deal, that there are a number of things that they have agreement on. Probably the one most important for our hospitals is a 3-year extension. Looks like it's going to be included for telehealth, which is great. It's something that I think everybody recognizes is kind of the best way to deliver healthcare in a lot of areas of the country. And so we're very glad that they're going to give that a little longer term extension. We hope they will eventually make that permanent, that, potentially could be part of a reconciliation bill in the new Congress. But for the lame duck to make that 3-year extension is a great win for healthcare. There should be a what's known as a doc fix. There's a provision that was calling for our doctors to have their pay cut, and looks like there's going to be a fix in there so that pay cut does not happen for our physicians. We certainly are very much opposed to any cut in payment for our providers. They do so much for so many, and it is entirely the wrong direction to go in cutting their pay. Um, Sadly, Medicare doesn't really reimburse them as well as it should in the first place, and then to kind of add that insult to injury would really be bad. So I'm very glad that both of those fixes appear to be in there. I think there's some other dogs and cats, um, but it would be part of that continuing resolution to keep the government funded. As we understand it, the continuing resolution will go through sometime in March. It's a little unclear at this point whether it'll be the middle of the month or late in the month, but that should give the new administration and the new Congress some time to get started on things.
Well, that
Well,
sounds
good.
like great news coming out of Washington then.
Well,
We do
temporary,
occasionally get that.
Except for,
te-
yeah.
temporary great news. It does have the end on it in March, but a new administration, especially Republicans having control of both chambers of Congress, although the House, who knows if it will be a functional majority based on the size, especially
Right.
once a couple of these appointments to cabinet positions get approved and those members cycle out, and we have to have special elections. But it'll be interesting to see what direction a kind of trifecta control, Republican controlled Washington takes on healthcare policy.
It is an important policy, but probably not the top issue. It's probably the second or third banana uh, when we start talking about federal policy. The president, obviously, or president elect, I guess he's both, had made immigration reform absolutely job one, and everything that we're hearing is that is in fact the focus as they're getting ready to go into office. But they're going to have to do a reconciliation bill because all of those 2017 taxes are going to come back, and it would amount to the largest tax increase in U.S. history if they don't take action and do a reconciliation bill. If you aren't aware, and I suspect the two of you are, but others listening may not be, budget reconciliation is a multi-step process starting with passage of a budget resolution that instructs other committees of Congress to raise or lower taxes, cut or increase spending on various programs. Those committees then have wide latitude in how they accomplish those goals. It's all bundled up back to the budget committee in each chamber and voted on again and then sent to the floor of each chamber. So it's a multi-step process. I know there are people who think that it's going to happen very quickly. I don't think it's going to happen particularly quickly. It's a little too cumbersome to be fast, and quite frankly, I'd rather that they get it right than get it fast.
Let's stay on DC as we look towards 2025, Jim, and talk. Let's start with Kentucky's role in Washington in general. Obviously, Leader McConnell is cycling out, is ending his tenure as the longest serving Republican leader in the Senate. But that doesn't mean that Kentucky will be left without influence. Obviously, Jamie Comer, Congressman of the First District, is Oversight Committee chair. Leader McConnell is going to be chair of the very powerful Senate Subcommittee for Defense Appropriations. But there's a possibility we might have two other Kentuckians as committee chairs, and one of those is particularly important to our industry, which would be Brett Guthrie, who is in the running, appears to be the front runner to be chairman of the Energy and Commerce Committee. He's currently the chair of the Healthcare Subcommittee for Energy and Commerce, which already holds, I mean, basically the entire U.S. healthcare system runs through his committee because that's Medicare, Medicaid runs through there. But talk a little bit about the oh, sorry, Jim's correcting me. But talk a little bit about the influence that Brett Congressman Guthrie can have on healthcare policy in this country from his position as the chair of Energy and Commerce.
Only members of Energy and Commerce think that all of healthcare goes through Energy and Commerce.
Well, being in front of the congressman, I'm gonna stick up for him.
Actually, healthcare is divided really between the Ways and Means Committee and the Energy and Commerce Committee in the House. There are other small parts of it, very, very tiny parts of it that other committees have a little jurisdiction over. But Ways and Means has jurisdiction over Medicare Part A, which is, of course, hospital payment. It also has jurisdiction over Medicaid. It shares jurisdiction with Energy and Commerce over Medicare Part D, which is the prescription drug benefit. The part that Energy and Commerce has is Medicare Part B, which is doctor payment, and the other part of Medicare Part D. So between those two, that is really where our healthcare system is in the House. On the Senate side, it's sort of not an exact mirror, but very similar with the Senate Finance Committee and the Senate Health, Education, Labor, and Pensions Committee, commonly referred to as the HELP Committee. It would be, to your larger point, great for Kentucky if Representative Guthrie becomes chairman of the full committee. He's been a great friend to healthcare in his perch as the chairman of the health subcommittee at Energy and Commerce. Would be even better if he's chairman of the full committee. He has a race, but he is widely acknowledged as the front runner in that. His chief competitor is Representative Bob Latta from Ohio, who chairs the communications subcommittee of Energy and Commerce. So it'll be interesting to see how that ultimately plays out, but everything that we're hearing is that Guthrie is the front runner and likely to be the new chair there. You correctly point out Representative Comer will be back at the chair at House Oversight. We are hopeful that Representative Andy Barr from Lexington will be chairing the Financial Services Committee in the House. It looks like Senator Rand Paul will be the head of the Senate Homeland Security Committee, and that actually has some healthcare implications as well, as I suspect Dr. Fauci is going to find out. Um,
Well, I think
as you know,
it's also important because that could play Senator Paul could play a part in helping reshape immigration policy, especially as it comes to bringing skilled workers, healthcare workers in, and allowing healthcare workers who have been trained in the United States to stay and work in the United States after graduating med school.
that's exactly right. It is potentially a huge benefit for us. And you're right. Uh, Senator McConnell will be chairing the Defense Subcommittee at Senate Appropriations. He will also be chairing the Senate Rules Committee, which is
Yeah.
uh, more of an inside game, but will give him lots of leverage in dealing with his fellow senators. And I know it's kind of a dirty word for a lot of people, but when it comes to deal making, he's going to kind of be in the catbird seat for a lot of deal making, and that won't hurt Kentucky either. When the senator was with us back a little over a month ago now, we were talking about it, and he said, well, just because I'm stepping down as the Republican leader doesn't mean that I will be completely without influence. And I think that was certainly a large understatement on his part.
I think when you look over at the House and see how Nancy Pelosi has operated since stepping down as either Speaker or Minority Leader, I think that would certainly indicate that just because you're no longer the leader, once the leader, always a leader. So,
That's exactly right.
Yeah.
And Senator Thune, the new majority leader in the Senate, was McConnell's chief deputy.
yeah.
And so I expect that if Senator McConnell calls, he'll take the call.
It's definitely still going to be a lot of influence there.
Let's look towards Frankfurt. As I mentioned, there was only a one seat change. One Republican lost, one Democrat lost in the House. Numbers stay the same in the Senate. The faces changed. We talked earlier in the year after the primary, kind of about some of the primary results. The insurgent, anti-establishment, whatever you want to call it, wing of the Republican Party, picking up a couple of new members, but not a significant change in the makeup of the caucus. Leadership stayed largely the same in the House for its leadership elections. The Senate, obviously, with Damon Thayer retiring, not running again, we have a new majority leader, Senator Max Wise, and we have kind of some changes underneath him. So talk real briefly just about kind of before we get into policy, the state of play vis-a-vis the healthcare industry for where we are with the makeup of the chambers and leadership.
I think the good news is KHA has fine relationships with leadership of both chambers and quite frankly with the rank and file. It's a case where the members of the legislature value their hospitals. They may not know a lot about healthcare in the entire state, but they know about their local hospital and the value of that in their community. And so I think that that is very helpful to us when it comes time to talk about policy changes. Um, we are we are glad to work with anyone who wants to work with us. Um, I think some of those who are viewed as kind of I'll use your term, the sort of insurgents. I think maybe that's not as uh, not as big a thing as sometimes it's made out to be. That there are issues that they are insurgent upon, but probably not on just everything as that might lead some people to believe. I think there are a lot of areas where there's common ground, and KHA always tries to look for that 90% of things that we can all agree upon. And once we take care of those, then we can fight like hell over the 10% that remains. But let's do what we can work together on first. And maybe there will be enough trust by the time we've worked on all those issues that last 10% doesn't have to be vicious either.
Let's talk about the 90 to start with. What are the kind of the key things on the pro side, things that are good that we that need to be addressed, but look positive to be addressed, that we're going to be looking at. Reminder, it's a short session, so it comes with some voting restrictions based on if there's money being raised or expended. It changes the threshold of votes. So it's a little bit of a different session than if it's a long budget session. But what are kind of some of the highlights of the things that from that 90% bucket you think that we're looking at KHA working on during session this coming year?
Well, Trey, I'm going to start with one that they won't actually vote on this year, because you're right. It's a short session of only 30 days, so they won't take up budget issues. And one of the issues that we really hope that they will focus on in the next session is providing some funding for our state trauma system. It doesn't require a huge amount of money, but it needs to be fully funded. There is a state mandate for the trauma system to be put in place, but the state has never funded it. And so we have been talking with members of the Appropriations and Revenue Committee in each chamber. And we told them, you could fully fund this for $750,000 a year, $1.5 million in the biennial budget that is multiple trillions of dollars. And they're like, oh, we didn't realize that it could be done that inexpensively. Yeah, let's talk about where this might appropriately fit in. So we want to keep that on their radar. It's on their radar right now. We want to make sure that it stays on there and doesn't fall off, because if that system is fully funded, the estimate is 45,000 lives a year would be saved, because you got to get people to the appropriate level of care quickly if they've been in an auto accident or some other traumatic event. And so fully funding that trauma system is really a great return on the investment. The number of lives that are saved will be huge, and the lives that are saved are likely to be of people between 18 and 45. They are the most likely to die from trauma. And those are valuable working years, not to be too crass and put it in economic terms, but saving those lives will really mean a lot of money for the state as well. So it's a great return on the investment for the state to do that.
That is a huge number that, such a small investment from the state could have that big of an impact on Kentuckians. I mean, it seems like a win-win for everyone to protect that many people for less than $1 million a year.
Yes.
Well, and
Yes,
also,
it's
so I also think about the back end. We often talk about the costs of delay of care for a variety of issues that Ginger we've whether it's sepsis or anything
Exactly.
else. We talk about the cost of the delay of care, and even the people who would have survived anyways, it's probably going to be a lower financial healthcare burden on the state and
Hmm.
taxpayers and whatever private insurance people may have by improving the system. So not only are you saving lives, but you're probably also going to decrease the long-term financial commitment for those who were going to live anyway, but you're now getting them treatment faster and ensuring a better chance at a better outcome that's going to prevent longer lasting chronic issues.
Right.
that
And
is an excellent point.
yeah, improved quality of life is even as, that's as good as saving life in the first place, is improving the life of those that already are going to survive. Huge difference for Kentucky.
Well, and not like Jim said, not to be crass and put it just in straight economic terms, but so much of our budget goes to treating people with chronic issues, whether it's chronic diseases, chronic pain, chronic injuries, and the more we can do to decrease the burden that falls on either insurers or the public via uh, Medicaid, that's the only way we're going to start bringing down some, the Medicaid budgets and the financial commitments to that area. So I think it's a great, especially for that low of a financial figure, it's a great investment there. What else we got that are pro things that you'll likely see a bill filed this session for?
Well, we are certainly going to be making another run at protecting the 340B drug discount program here in the state. As I know you and Ginger are already aware, a number of pharmaceutical companies have kind of taken the law into their own hands and said, we're not going to deliver drugs at the agreed upon 340B price that they set, by the way. The hospitals don't set that price. The drug companies set those prices, but they've said, we're not going to deliver them uh, And that's going to be a real problem, is a real problem already for many of our hospitals because they use the savings from that program. Everybody knows how expensive the prescription drugs are. And the hospitals use the savings from that program to provide things like oncology services or free or low cost prescription drugs, or they run Hep C clinics. And those kinds of things will, by necessity, go away without the savings from the 340B program. And we've seen a number of other states already implement such laws. They've been successful. The pharma companies have challenged them in court and lost everywhere that they've challenged them. So we have a very straightforward plan. We want the pharmaceutical companies simply to treat our hospitals and our contract pharmacies the same way they do the hospitals in Missouri and Arkansas and Louisiana and Maryland and about a dozen other states. In fact, there are probably 19 other states that are already working on moving forward with this legislation this year. What it comes down to for members of the legislature is very simple. Are you going to stand with your local hospital and your local pharmacy and helping them so that the money is spent here in Kentucky for the benefit of your constituents, or do you want to see those dollars stay with the big pharmaceutical companies to enrich their CEO who lives in Geneva or Hackensack, New Jersey, or somewhere other than the Commonwealth of Kentucky?
And I know here at KHA, we've been studying 340B for a while and really working with our hospitals on, how they're using those savings that they're receiving from the drug manufacturers. And if they lose that savings, all those programs that they are funding, someone else is going to have, are we going to have to pay for those somewhere else? Or are we going to lose those services that hospitals are footing the bill for out of that savings? Like, I know 20% of those 340B hospitals are using it for community health programs and things that they're funding completely free for their patients. So who's going to foot the bill for those, or are they going to disappear for our patients?
Well, that's it exactly, Ginger. And I've asked members of Congress when they've told me, how much pharma is spending on these programs, and I said, well, pharma only cares because pharma is spending the money. If pharma doesn't spend the money, we're going to have to turn to you for the money, and you're going to have to ask the taxpayers for more money. So isn't it really better to have the pharmaceutical companies, none of which really seem to be hurting for money?
Exactly.
Isn't it better to have them funding this than asking the taxpayers to pick up the slack? It's a case of the pharmaceutical industry wanted to be at the table for negotiation of the ACA, commonly known as Obamacare, and the price for that was agreeing to expansion of the 340B program. And so they got what they wanted at the negotiating table with the ACA, and now they don't want to have to carry through on the expansion of the 340B program. So it's nobody has to take Musser's word for it. It's all out there. They can fact check me, but that's where we are. And we've got to take care of our patients. This program has been extraordinarily effective in helping us to be able to do things that we wouldn't be able to do otherwise. It's a matter of some of the small communities, it's access to care. The savings allows them to keep the lights on and the doors open. And in others, it is, as I said, providing free or reduced cost prescription drugs. It's providing social determinants of health assistance through transportation to healthcare or food or clothing. It's really used for quite an array of good things. And it's kind of laughable because one of the arguments that the pharmaceutical companies like to make is, oh, well, the patients don't see the benefit of the program. That's just simply not true.
Yeah, all around it is.
And I'll say this too, when it comes to when it comes to policies like this, obviously sometimes elected officials have to weigh a whole multitude of interests and different angles on it. And but Kentucky's in a strange position. Most others, and I think this is true, correct me if I'm mistaken, but most other states have at least some level of manufacturing, white collar base, some sort of actual economic base from the pharmaceutical industry. I'm sure if we're in Indiana with Eli Lilly, it might be a different calculation if you're a legislator talking about this program. But in Kentucky, like I said, we're one of the few that has no real. We have nobody other than drug reps. There's no white collar, no HR, no research facilities, no manufacturing facilities for the pharmaceutical industry in Kentucky. So, if I'm a legislator looking at it, weighing one against the other, it becomes a much easier call for the Kentucky legislature than it may be in another state because that all you're doing is helping patients. There's not another financial calculation to make here.
That's right. And your very point, our hospitals employ over 84,000 people in this state. And if the pharmaceutical manufacturers are employing anybody, I'm not aware of it other than their lobbyists.
Yeah. All right. So is that it for the positive stuff? For the things we want to pass? Or is it time to move to the things we want to stop?
I think that's it. Well, and it may be kind of a mix because I want to
Yeah.
turn to one of our perennial favorites, the Certificate of Need program.
Which
Um,
we're okay with passing some stuff, just not everything.
that's right, because we recognize the need for some reforms in the program. Uh,
Absolutely.
we think that it would be beneficial to our patients to have some reforms passed. What we are not in favor of is taking our hospitals out of it. We are not in favor of removing it for big investments. We think that there are probably, I don't know, 8 to 10 things that it really needs to stay on. And the other things, we certainly should talk about how to reform it. Um, we will, of course, fight very hard to maintain the Certificate of Need program for our hospitals. Um, and I think the way things played in the last session of the General Assembly indicates that there's strong support for the program amongst the members of the General Assembly. They understand the danger of cherry picking, um, where an ambulatory surgical center could open up and take private pay patients, leaving hospitals only with government pay. And of course, we have to have the right payer mix in order to be able to offer the services to the public that we do. I think most people, Trey, don't understand that obstetrics and oncology and behavioral health are all money losers for the hospital. Actually, the emergency department is a money loser for the hospital.
Yep.
Those all have to be cross subsidized by other parts of the hospital that make money so that we can offer those programs so that people can receive treatment close to home. I like to use oncology as an example. I think everybody can understand if someone is sick with cancer, the last thing they need to do is have to travel for treatment. It adds a whole another level of stress and cost, and in fact, a level of risk if they're having to travel to get treatment that they should be getting close to home. And um, CON has helped to make sure that we have services, particularly in rural communities, that otherwise would not be there.
I think you and I discuss this offline all the time, Jim, that you and I specifically are both uh old school when the Club for Growth was cool, Club for Growth, fiscal conservatives, small government, as pro capitalism as you can get. However, we both have, for a variety of reasons, we both support some level of certificate of need because of the recognition. I think sometimes people forget that our healthcare system is the least capitalist sector of the entire U.S. economy. We discussed earlier the physician reimbursement rates. It's going to the federal government. And when you have 60-70% of people in a Kentucky hospital on any given day, their stay there is being paid for by the federal government. That gives insurers a whole lot of power to just say, well, we're just going to reimburse what the federal government does. So even
Mhm.
the people who are on private insurance, the terms by which the providers are being reimbursed are still being set by the government because they're basing their rates off of Medicare and Medicaid. So, I think that it's important. And I think some of the people who want to just get rid of certificate of need totally, they come from our wing of the way of thinking about government spending. But when it comes to healthcare, uh, if you don't, you can't change it at the state level, and you can't do it with certificate of need. It's got to be done at a federal level to completely change the entire playing field, which I don't think is ever going to happen. Where it's kind of too entrenched, but I laud anybody who tries to do it. But so I think certificate of need is the most visible representation of the fact that we don't operate in a capitalist healthcare economy, and so changing it without changing the way that it functions broadly, it's all it's gonna be is bad. It's not gonna bring the good that you think it would bring because it's simply not a capitalist system.
That's exactly right. We have certificate of need because we don't have a capitalist system in healthcare. Removing it isn't going to suddenly create one. I know a lot of people, as you say, from our side of the argument, look at it and say, "Oh, well, look how much more competition there would be." Well, not exactly, and probably not the kind of competition that you necessarily want, given that the system itself is government mandated. It it's a bit deceptive if you haven't been on the inside of healthcare. It's easy to look at it and say, "Oh, well, we'll just do this free market fix and everything will be different." What we have ultimately done as a society is we have made a decision, rightly or wrongly. The decision was made more than 50 years ago that healthcare is different from the rest of the economy, and we're not going to treat it the same way. Healthcare is regulated more than any other industry except perhaps nuclear energy. So think about that.
Yeah.
And I mean, one of the reasons why people want to see that more competition is because it's always assumed that more competition is going to mean that costs are going to be lower for uh, anyone that's going to be paying for their health care. But the CONs, the states that do not have CON anymore aren't necessarily receiving those lower costs.
No, they are not. You're exactly right. Multiple studies, uh, most recent one from the Rand Corporation, indicate that Kentucky has much lower healthcare cost than many of the states that have no CON. So there's not really a strong correlation between getting rid of CON and controlling costs. What we are likely to see, though, you know, it's interesting the way people think about things. The complaint is often, well, I have long waits to see the doctor, or I can't see the specialist that I want to see, so we should have another hospital. The problem is there aren't people to staff
Yeah.
that
Right.
hospital. And so the new hospital is either going to have to poach people from the old hospital, or it's not going to be able to offer the service. And in either scenario, the patient isn't going to see a specialist any faster because the specialist doesn't exist. And that goes right back to Trey's point about being able to make sure that physicians who are trained in the United States, if they've come here from the Philippines or India or Poland or wherever, and they've trained in the United States, can stay and practice in the United States. Or if they're trained overseas in a facility that we would recognize as, the American University in Cairo or the University on Grenada that routinely train medical doctors, and it's Americans who are training them, we'd love for those physicians to be able to come here. And so we're hopeful that perhaps Senator Paul can help us on that front. You know, they're when you start pulling the threads, the whole garment falls apart because it is just one big interconnected mess.
It's basically almost as much as anything in the entire economy. It is almost limitless demand, and the supply is defined by the number of seats available in med school programs, the number of seats available in nursing programs, and there's only so fast you can even if you were to just open the doors, let anybody set anything up. There's there's only so fast that training programs could ramp up to prevent you from having unqualified, dangerous individuals being the ones providing the care.
Well, that's exactly right. And one of the other good things that we want to do during this session, and we've already talked with Chairwoman Mosier, and she's told us she's going to have us on the agenda at some point. We want to talk about the success of the hospital rate improvement program. Uh, it is not a cost to the state. It is a means of allowing us to draw down additional federal funds, which we have used exactly the way everyone would want us to. And we are as thrilled as we can be about the success of the program in making positive changes to the quality and the health outcomes for our patients. You know, it's kind of amazing, and Ginger and I have talked about this from time to time. When you have the money to invest in it, the changes that can take place. And so before ATRIP, the hospitals were seeing readmission rates at a double digit percentage, and now it's in the low single digits. It's almost non existent. And that's a huge help to the health outcomes of our patients. It means there's a lot less infection. A lot more people are being caught early for sepsis, and we're seeing much better health outcomes. And it's tied directly to what we've been able to do with those ATRIP dollars because we have been able to invest in sepsis programs. We've been able to invest in opioid abatement. We've been able to invest in all sorts of training, and it's making a difference. And it's exactly the kind of outcome that we want to see. And it's really moved the needle in a very short time. And so we want to thank the members of the legislature for their support at the state level to allow us to draw down those additional federal funds, but we want them to see what's been done with that money. We very much want to be transparent about the use of it. The funds have been used exactly the way CMS at the federal level and the Department of Medicaid Services at the state level would want to see them used, and the way we want to see them used because it has improved the health outcomes for our patients. And that's a win. That's been a win for everybody that's been involved.
I think that's a really good point to make because we can show, what that kind of investment in the hospitals and the healthcare system are, what kind of rewards we're getting from that. And it kind of ties in also with the certificate of need protecting those services as well. Because, we just had two more studies come out like in the past week or so about rural hospitals closing their maternity wards nationwide and closing hospitals, exacerbating health inequalities in rural areas. And those are the exact things that we don't want to happen in Kentucky. So, we know that these things are happening nationwide, and it's good that our legislators in Kentucky are doing some things to prevent, bad outcomes like that in our state.
Before we let you go, Jim, because we're running a little bit longer than normal, but I think it's all good info that the listeners will want to pick up. I know you were on Issues and Answers recently down in Hazard on WYMT, and I know one of the things that you guys talked about was the Appalachian Investment Project. Wanted to see while we've got you, if you wanted to just give the little quick elevator pitch for that and talk about it briefly.
Thank you, Trey. I absolutely do because it is the same type of program that the ATRIP program is. we are seeking a value-based pilot project that would help the 9 neediest states in Appalachia so that they could invest in the kinds of things that they need to do to improve health outcomes for their people. The whole idea behind the program is to take people from dependence to self-sufficiency. And that starts on the solid foundation of good health. And unfortunately, our hospitals are paid less than the national average by Medicare. A lot of people don't realize, in fact, a lot of members of Congress don't realize that hospitals aren't paid the same everywhere for the same services. And so Appalachia, which has the sickest population, one of the oldest populations, and one of the poorest populations, is being treated with less of an investment than lots of other areas of the country. And it's hard to expect better outcomes for some of the sickest people in the country when we're not investing in their health care. And so we're not looking for a big money grab in this. All we're asking is pay our hospitals at the national average, and we're also seeking a little a little bump for the social determinants of health, really focused first and foremost on food insecurity, because without proper nutrition, you can't recover from an illness. And so we think that we have devised the right metrics that we can show how we would invest the money and over the next few years start showing how people's health is improving because of those investments. You know, our people are as deserving as the ones in California and New York. We need to have the resources to bring in the specialists that they need, to invest in the equipment that they need to diagnose and treat their diseases. And the Appalachian Investment Program would be a huge step toward doing that. A little longer than an elevator speech, but it's an important project.
Definitely.
I'm sure we'll probably have another podcast focus on that at some point in the future. So we will we'll just leave that to whet people's appetite.
Exactly. A little preview.
Jim, if KHA members want to get involved, want to help push the issue, want to help with KHA's lobbying and advocacy efforts, what's the best way that they can get involved?
We would certainly welcome that. As I always say, the members of the legislature have to hear from the KHA. It's important that they hear from us as the voice of all the hospitals in the states. But there is no substitute for the members hearing from their own constituents, including their hospital, their CEO, their board members, the nurses, and all of the wonderful people who work in our hospitals. And you are working with our connection. Ginger Dreyer is the person to contact.
Exactly. Anybody can reach out to me anytime and make sure that they get involved with our grassroots advocacy efforts because, like Jim said, you know, we have a great team here at KHA working on advocacy, but nothing compares with a member of the legislature hearing directly from a constituent and how their work is impacting the hospital. So if you go onto our website, which is www.kyha.com, under the under the menu, there's an advocacy section, and we have something called Voter Voice. You sign up for that, you'll get alerts anytime that there's a big piece of legislation that's going to impact healthcare in your community, and you can, with 2 or 3 clicks, go ahead and send an email directly to your legislator and help them understand, you know, what's going on in your town and how this can impact you and other Kentuckians around you. So please do that anytime. And also for our members, and this will be kind of like a little save the date, February 13th is going to be the KHA Hospital Day at the legislature. And that is also on our website. If you want to get that added to your calendar, registration is already available, and we'll have details coming on our speakers and the full day's agenda coming soon.
Fabulous. You know, Jim, you know this. There's the nattering nabobs out there will say that legislators are owned by lobbyists. They're not. They're owned by their constituents, and
That is exactly right.
that's why it's important. There's only so much that yourself, Travis Burt, and the rest of the government relations crew at KHA can do. Uh, and it's vastly out impacted by one call, one email, one touch from someone back in the district.
And the great news is Ginger makes it so easy. The voter voice system is so easy to use, and Ginger puts a superb explanation of the issue. Everything is done for you. All you have to do is read and click. It's simple and so effective.
Absolutely. Ginger, do you have anything else to add from the member info portion?
Those are the big things. Like I said, we've got events coming up in 2025 that everyone will want to be a part of. So keep an eye out on our events calendar at kyha.com. We'll have all the info out there for you as soon as we have it.
All right, Jim Musser, thank you for coming on to preview the upcoming legislative sessions.
Thanks for having me. It's always a pleasure to be with you guys.
We appreciate
Absolutely.
it.
And as always, you can get the KHA podcast wherever you stream your podcasts. If you get us on Apple Podcasts or really anywhere that allows you to leave reviews, go ahead and leave us a good review. Make sure you follow so you get a notification when there's a new podcast posted. And we will be back with you next time on another KHA podcast.